All right, we are back live on YouTube. This is Senate Health and Welfare Committee meeting, and we're resuming our discussion today about S90, the ALS registry, and we have a number of folks to testify, beginning with former Representative Ann O'Brien. Ann, thank you for being here, and we very much look forward to your testimony on this important bill. So why don't you introduce yourself for the record, and then, you know what, before you do that, I know that you probably know everyone who's here from the committee, but I think we'll just take a minute to introduce ourselves, and then that'll suffice for all the other witnesses. So I'm Senator Ginny Lyons, Chair of the committee. Ruth?
Good morning, I'm Senator Ruth Hardy from the Addison District. I'm the Vice Chair.
Hello, I'm Cheryl Hooker, Senator from Rutland County.
And I'm Ann Cummings. I'm the senior member, and I'm from Washington County.
All right, terrific. And Senator Terenzini is unable to be with us today, but he is also a member of the committee. So Ann, why don't you introduce yourself for the record, and we look forward to your testimony.
Great. Thank you so much, Senator Lyons, for having me today. My name is Ann O'Brien, and I am here to give input on S90, an act creating an ALS registry. I did serve as Richmond State Rep for 8 years, 6 of which were on the Appropriations Committee, and so I'm much more used to sitting on the listening side of this table than on the speaking side. But I really appreciate all the work you're doing here very much. I am a registered nurse, and my husband, Keith Franz, was diagnosed with ALS in 2018, and he died in 2019. I hope this bill is a seed, like I'm a gardener. I hope this bill presents a sort of seed in the gardening sort of way. It's a small thing to create a registry, but it could lead to much bigger things in terms of improvement in the prevention and treatment, and hopefully one day a cure for ALS. ALS is considered rare. Like as a nurse, we always say this is a rare disease. And so of course I was surprised when my husband was diagnosed with it, and also very surprised as I got into what I'll call the petri dish of ALS, the ALS community. A wonderful group of humans. However, I was so surprised to learn more and more about people with this diagnosis. And I do appreciate that we were just sort of in it, but it surprised me when someone came to our home to help out with some services here, support services. And after she had been here a couple of weeks, she said, you know, my son died of ALS 2 years ago. He was 40 years old. And she lived right in the neighboring town. And then as I shared Keith's diagnosis with people, a friend of mine said, this is, you know, gosh, Ann, just 2 weeks ago, a colleague of mine was diagnosed with ALS. And then I learned of, you know, a younger person in Heinsberg who had it, and someone in the Northeast Kingdom. And a woman from my town wrote me a note and said, you know, I'm so empathetic. My husband died of ALS, and I'm right there with you. And she was from Richmond. So I'm much more science-minded than anecdotes. And I'm like, what's the data on this? Is there any kind of data? Like, I'm hearing all of these things. And so when Keith was attending the ALS clinic at the UVM Medical Center one clinic day, I just posited to the therapist there. I said, you know, what's the data? Is there any data? And like, I'm aware that I'm sitting among all these people with this diagnosis, but seems like a pretty high prevalence. And the therapist comment was, you know, there's an oddly high number of people with ALS in our region, but didn't really know what the actual data was. So on top of all of that, Keith himself had a dear friend in Plattsburgh, New York, which is where he lived for quite some time, just across the lake. And this friend had died from ALS just a year or so before Keith. So all of these are anecdotal stories of people. And they do not, of course, create the basis for any conclusion, except that Vermont needs real data on this, and Vermont needs an ALS registry that's based on actual diagnostic codes. The data are important to determine the incidence of the disease in our state, as well as to contribute to the accuracy of the ALS National Registry. And the ALS National Registry is voluntary. So for example, when Keith was diagnosed, he was asked to join that. And his response was, I'm not going to be part of that club. So my point is, it's a voluntary registry on the national level. And maybe Keith got in there from some other angle, but he did not sign up for it because it was voluntary. So I think having a registry that is set up as based on real data that can give real facts is very important. Everyone knows that data can inform research about the incidence and geography and any other common elements that could lead to a better understanding of what might be triggering this neurodegenerative disease, and then hopefully be leading to better treatment and prevention and possibly even a cure. So I do have 3 recommendations for the bill itself and improving the bill. And the first one is I would recommend adding the word de-identified data in any part of the bill that talks about collecting confidential data. I think it's really important to be clear that this is de-identified confidential data that's being shared. And I didn't go line by line through the bill, but anywhere in the bill that it would say confidential, I would put de-identified. A second thought that I have in reflecting on the bill is to really reevaluate the $500 fine, $500 per day fine, which is now in the bill, at least as a placeholder. If any fines were collected, they'd be going to the general fund. And to me, that seems like, there might be a better use if fines were collected, which I think that there would be, hopefully there will be no fines collected because there's interest in making this happen. But would there be any money? It seems to me that it would be wiser to put that money towards people who have the diagnosis of ALS and need to purchase occupational therapy aids. I mean, they're so expensive and they're not covered by insurance. Things like something to help you out with your computer and something to, magnet clothes that you can dress yourself easily with. These are not covered by insurance. And it seems to me that hopefully there will be no money collected, but if there was money collected, that it should go towards individuals' needs related to ALS. And the third recommend that I would have is probably more in the realm of the commissioner, because I do appreciate that the bill puts it on the commissioner to create a system. But to really, I would be asking the questions, if I were you on your committee, to be evaluating whether the vital or electronic health record system used by Vermont hospitals could just be programmed to send de-identified confidential reports by diagnostic code to simplify the process and make it simpler. And perhaps you're already thinking of that. So in conclusion, my short testimony here is that there is no doubt that ALS is a devastating disease. And if one little small trim tab bill like this one to create a registry can add knowledge and data to put together the pieces of the puzzle, to find some clues that would lead to prevention or treatment, or perhaps even a cure, then this bill, this little small bill, actually becomes a very important small big thing. And I really appreciate your taking the time for my testimony. And thank you so much, Jenny, for inviting me to participate in this conversation.
Thank you very much, Anne. It's a pleasure to have you in our committee. And we would like to share our empathy, concern about your loss. And because we do know how devastating this disease is and how quickly it manifests and progresses. But so, and I do have an ask for you, and that is if you could provide your testimony in writing. If you have, I know you don't have a lot of minutes, but if there's some time that you could do that, that would be terrific. Because
Certainly.
the 3 recommendations you make are important to us, and we certainly need to look at those as we go through the bill. Questions for Representative O'Brien. Thank you very much. I really appreciate what you said about sort of listening to the stories and sort of kind of the idiosyncratic information versus firm data. And I think that's what we're all concerned about, because we have heard so much from our friends and colleagues, and we know people who have experienced ALS in their families or personally, and that having a firm grip on information makes a lot of sense, at least to those of us in the committee right now, and also to Senator Terranzini, who is very supportive as well. So any other questions, committee? Comments? We're good? We're good.
Thank you.
Thank you, and thanks for your time. Greatly appreciate it. All right, so we'll move. If I can find my agenda again, there it keeps disappearing, but there it is. So thank you all for being here. Dr. Stommel, you are next on the list, and I know that you have been very much involved in the area of ALS. And so if you don't mind introducing yourself for the record, a little bit about your background so that folks can understand the work that you do at Dartmouth, and then we'll hear your testimony.
Thank you for this opportunity. Can you hear me okay?
Yes.
So I'm a neurologist with an interest in neuromuscular neurology here at Dartmouth. I've been here at Dartmouth for over 30 years now. And Dr. Tandon, who is also a participant in this conversation, and I see probably the majority of ALS patients in Vermont. It's a devastating disease, as Ms. O'Brien said, and it's a very, very frustrating situation to have these patients come into your clinic and you really don't have a whole lot to offer them in the way of a good therapy. On the other hand, it's a disease that's rare, but it's related to some other neurodegenerative diseases like Alzheimer's disease, Parkinson's disease, which aren't so rare, yet they have similarities in the underlying pathophysiology. And ALS, out of those 3 major neurodegenerative diseases, is probably the easiest one to handle because the cases are easy to ascertain once you get to see the patients, unlike Alzheimer's disease, which can take a long time. And there's always a little bit of uncertainty in the diagnosis. And in terms of studying a disease like ALS, it rapidly progresses generally, and it makes it in some ways an easier disease to study. All of these diseases likely have some underlying genetic susceptibility and some environmental influences, and probably many, many environmental influences, which are very important to understand. Dr. Mehta, who's part of the CDC, who's on this call as well, can tell you that there's a great interest in risk factors for ALS. And the CDC does supply grants to look specifically at this type of question. As a clinician and a researcher of ALS, I find it frustrating that we're missing many of the cases. And Vermont has a history in studying ALS. It's the first state in the country to actually find and study an autosomal dominant form of ALS in the FAR family, which predominates in the Northeast Kingdom. So there's some precedence in Vermont for an interest in ALS and understanding ALS. The majority of ALS is not genetic, as in the FAR family, but it's important to recognize that subcategory of ALS. If we were to understand the risk factors and the genetic underpinnings of the disease, we would certainly be able to come up with better therapies and mitigations to prevent disease. And one of the risk factors that I've spent a lot of time researching is the Cyanobacterial Toxins, which of course are quite prevalent in Vermont and New Hampshire and all over the world for that matter. But we have found clusters of ALS along Lake Champlain and some other parts of Vermont in close proximity to cyanobacterial blooms. That being said, it's clearly not the only risk factor for ALS. And when we made an effort to get a ALS registry formed in Vermont a few years back, that was one of the complaints that we didn't have hard facts about cyanobacterial toxins being a cause or potential risk factor for ALS. But we have looked at many, many risk factors at this point and are trying very hard to identify them. To do that properly, you need to ascertain all the cases in any geographical area that you're looking at. And I would say that between Dr. Tandon and myself, we're probably ascertaining, probably 75 to 80% of the cases in Vermont. Some of them go to Massachusetts, to Mass General. And some of the cases we just don't know about because they're in a rural environment. They're largely taken care of by their family doctor or even misdiagnosed. So, to have good science, you have to have a good infrastructure. And that's really, really important. The National Registry has made great bounds in collecting data on ALS patients. But as Ms. O'Brien mentioned, it's not a mandatory registry. And the only state in the country that has a mandatory registry is Massachusetts. And the reason they have a mandatory registry in Massachusetts is that Governor Cellucci died of ALS, and they wanted to do something in his memory. So they started the registry there. And we are, at least at Dartmouth, have been very interested in getting data from the Massachusetts registry. And we have written some proposals to do just that and to look at risk factors carefully. We would love to have Vermont follow suit. And I think it would be good for the people of Vermont. It would be very good for Vermont itself. I've tried to get a registry in New Hampshire going. There's been pushback because of the what is perceived as a prohibitive cost to start a registry, a mandatory registry. And in the letter that we wrote, Dr. Tannen and I wrote, we point out that Vermont is a relatively small state in terms of population compared to a state like Massachusetts. And we have funds at Dartmouth and at UVM that could be used to pay for the infrastructure of a registry. And I don't foresee the state of Vermont having much of a bill at all. And we have a good infrastructure with residents, fellows, other attending neurologists who have an interest in ALS at most of these institutions, who could certainly help collect the data in a de-identified way and supply it to the National Registry, which would have the ability to secure the information in a database. And I would have Dr. Maida talk about that. Registries are not uncommon. The registry that's presently going on for COVID, for other infectious diseases, for cancers, are all very much accepted and paid for. The large registries are paid for in part by the government, not necessarily by the state government, by the federal government. But ALS is no less serious a disorder. And as I pointed out, is related to other neurodegenerative diseases that are very common. And I think would behoove the state of Vermont to think seriously about having a registry like this. So I think maybe I will stop there. I very much appreciate the opportunity to speak, and I hope very much that something can be done to help our ALS patients in Vermont. There are many reasons to have a registry, not just for research, but for the clinical needs of the patients as well. Thank you.
Thank you. That is very informative on a lot of different levels, and we appreciate it. I think we'll keep going with testimony, and then we'll open up for questions after we've heard from folks. So, Dr. Tandon, thank you for being here. I'm glad you finally made it into Zoom. Sometimes it's frustrating, but welcome. Why don't you introduce yourself for the record, and then we welcome your testimony. And before you do that, let me just ask if you have, Dr. Stommel, if you could provide some written testimony for us. I know you sent the response letter to Dr. Levine from 2019, but it would be helpful to have the testimony that you've just given as well. So that would be, if you can do that.
Do you have access to the letter that Dr. Tannen and I wrote?
Yes, that's on our webpage.
Okay.
Yep. So we have that, and we have the letter that was sent to you from Dr. Levine, and then your response to that letter. Yes.
Okay.
Okay. And
Great.
So Dr. Tandon, likewise, if I'm not sure we have your testimony on our webpage, but it would be helpful to get it. So we'll listen. Thank you. You're muted.
I'm unmuted now.
Yes,
So
you're unmuted. Terrific.
I'm unmuted. Can you hear me
Yes, you
well?
are. We hear you perfectly.
Good. Thank you for inviting me to give testimony at this committee, St. Alliance. So I am like Dr. Stommel, I am a neurologist and neuromuscular specialist and trained in nerve and muscle diseases and also in ALS. I've been seeing ALS patients and doing research in ALS for the last 36 years. And I've been director of the National Als Center of Excellence at the University of Vermont for the last 34 years or so. So we see a lot of patients with ALS. I think that in full agreement with what Dr. Stommel has said is that there's a dire need to consider a mandatory registry for ALS patients in the state of Vermont. There are many reasons for that, many mentioned by Dr. Stommel, but I'll add to that another list of reasons. So one is that even though ALS is a non-familial disease, i.e. about 90% of patients do not have a family history of the disease, we now know, and 10% of people have a family history of the disease. We now know that many genes that have been associated with familial ALS are also found in people with non-familial ALS. So that's one important fact. So what we learn from familial ALS, we can take to non-familial ALS as well. The second thing is that there are many new treatments that are coming about in patients with familial ALS that are being currently studied across the country. And these are mainly gene-based therapies, and therapies that either suppress genes or replace some genes, etc. So those treatments are going to be available to people who have non-familial ALS as well. If patients with ALS are in the community and not recognized as such, which is not uncommon at all. In fact, in the note that I sent you, Senator Lyons, and that Dr. Stommel and I created, almost a third of states or chapters see patients with ALS that are not affiliated with, say, treatment centers or clinics with ALS. So they have them registered, but they are not being seen in clinics or centers of ALS importance. The idea there being that if they are not going to these clinics and centers where ALS expertise is available, then they are missing out on, number one, a concrete diagnosis or a misdiagnosis. And, you know, there are patients with ALS who are misdiagnosed with ALS. Then number two, they are not reaping the benefits of some of the support that is available to patients with ALS through these specialized centers of excellence as well. So, for example, as Dr. Stommel mentioned, physical therapy, occupational therapy, speech therapy, language therapy, dietary and nutritional services, they may not be available to patients or to all the patients unless they really are seen in these specialized centers of excellence. The other thing is that a lot of the chapters in the country, including our chapter, which covers Vermont, New Hampshire, and Maine, the ALS chapter, supports patients and families with ALS so that they have support groups, they do home visits, they provide social services to patients, they provide home care to patients. They also have bereavement groups, which are so important for families with ALS, and they provide groups for children who come from families with ALS. So important to support patients and families with ALS. The psychological stress and burden is not only great on patients, but also on family members. In fact, some studies suggest that it is greater on family members than it is on ALS patients as such. The other thing is that there are now treatments available for or coming about for people who may be at risk for getting ALS. So for example, there is a type of ALS due to a mutation in a gene called the SOD1 gene. And there are studies available being undertaken in the US, in Europe, and in Australia, where people who are at risk and who agree to be treated are being included in these studies, and they are being given treatment to either delay or prevent the occurrence of the disease. So that sort of therapeutic approach is only available in specialized centers of ALS, which means that we have to know where these patients exist. So having a registry is going to be so important to make sure that we reach all the patients with ALS and not just 80% of patients with ALS in the state of Vermont, or maybe in the country as well. So those 20% of patients are missing out on these services, on these therapeutic approaches, etc., that we have to offer them. So I think for all those reasons, it's important to make sure that we have an accountability and ascertainment of all the patients with ALS, not only in Vermont, but also in New England and also in the country. And I'm sure Dr. Mehta will talk about that as well, because he just has a paper that's coming out soon from the National Als Registry that talks about that, the importance of having registries. So I think that I will maybe end my testimony here, but again, reiterate that it is so important to make sure that we account for and ascertain all the patients with ALS in the state, for the reason that, number one, we need to know that they exist so we can provide them additional help and services, and that we can correct the misdiagnosis if there is a misdiagnosis of the disease in those people. We provide them the services that they direly need. We refer them to our VA hospital in White River Junction that can give veterans with ALS significant support and help that they need. And that's a tremendous piece of support that the veterans get through the Veterans Administration system. And we need to identify them, because a lot of veterans don't even know that help exists for them. So it's important to know about those. And then offer patients clinical trials that are being conducted through our center, the center at Dartmouth, and other centers as well. That is going to be so important for patients to participate in those trials, because that's how new treatments are going to be available and going to be tried and then be available to the ALS community at large. So for all those reasons, I think that it's important to have an ALS registry in the state of Vermont. Thank you for listening to me.
Thank you for sharing your testimony. This is very helpful. And again, your testimony in writing will allow for us to go through it and digest it a little bit more. And so if you could provide that, that'd be great.
Will do.
Okay. I'll save my question for later, as we said we would. Dr., is it Mehta or Mehta?
Mehta, ma'am. Thank you.
Mehta. Well, thank you for being here. We appreciate the time that you're taking to inform us about the National Registry, and we would be helpful for you to introduce yourself, and then we'd listen to your testimony. And I'm looking to see, yes, you have sent us some written testimony, and Rep. Tandon also sent us some testimony. So we aren't fully blind to what you're going to say, and that's helpful. So why don't you go right ahead, introduce yourself, and we'll listen to what you have to say.
Thank you, ma'am. My name is Paul Mehta. I'm the PI, or the principal investigator of the National Als Registry, which is housed at the CDC, ATSDR, Centers for Disease Control and Prevention. And so this is my testimony. You already have it, ma'am. So I'll go ahead and quickly just begin. So the National Als Registry launched over 10 years ago, and it's the only population-based registry in the US. It's the largest population-based registry in the US for ALS. Its purpose is to better understand who gets ALS and why. This is done by determining the epidemiology of ALS in the US and evaluating the risk factors as well. We do this largely by funding research to better understand the causes and risk factors for ALS. We also support the recruitment of clinical trials for drug companies, as well as epidemiological studies as well. And this is done through our research notification mechanism, where drug companies come to us and we'll go ahead and send information about the clinical trial to our patient database, and it's done all pretty much anonymously. The patients will go ahead and contact the drug companies or the actual institution who's doing an epidemiological study. We also collect blood tissue for the purpose of evaluating biomarkers, genetics, through the National ALS Biorepository. We also, like I mentioned earlier, look at the epidemiology of ALS, the incidence, the prevalence, and the mortality of ALS. And it's very important to also evaluate the public health disease burden of this disease. As the previous individuals have already mentioned, Dr. Stommel, Dr. Tandon, as well as the nurse as well, ALS is certainly a very, very devastating disease. It's a life-changing event. It's a rare disease, but what I like to say, it's not a rare disease for anybody who gets it. ALS, like most non-communicable diseases in the US, is a non-notifiable disease. What that means is it's not reported to CDC by state health departments. As such, we go ahead and look at disease cases or case ascertainment by a novel two-pronged approach. And this is done by getting cases or data from the Centers for Medicare and Medicaid Services, as well as the VA system as well. Patients also enroll they can self-enroll voluntarily at the National ALS Registry. And from there, they can go ahead and take a series of risk factor surveys we have to go ahead and ask about where did you work, were you in the military, and so forth. These are 18 risk factor surveys we currently have, which kind of do a deeper dive regarding exactly what may have caused their ALS disease. They also will go ahead and opt in for the National ALS Biorepository. We'll go ahead and give them information. The registry, as we like to call it, is a multifaceted research platform. We do a lot more than just count ALS cases. We also fund R1 grants as well. We have the biorepository I mentioned, and we also work with partner organizations such as the ALS Association, Muscular Dystrophy Association, as well as a group out in Chicago called the Les Turner ALS Foundation as well. So the registry is continuously searching for ways to improve data collection activities that will expand the sources of new cases from our current registries, nonprofit organizations, and clinics. We feel this is very important since ALS is not notifiable or not reportable at this time, with the exception of what Dr. Stabile mentioned. Providers in the state of Massachusetts are required to let the state know who's got ALS in that particular state of Massachusetts. This is also important. No one knows what causes ALS yet. We know ALS impacts whites, especially males, more so than any other group. ALS is more common after the age of 50. And like I mentioned, one of the goals of the registry is to figure out what causes ALS. I like to say there are more unknowns than knowns about ALS, and we're certainly looking to find those unknowns and get the answers and so forth. I mentioned the 18 risk factor surveys we currently have, and these risk factor surveys, just to kind of quickly go ahead and do a deeper dive, they look at, did you serve in the military? What hobbies did you play? What sports did you play? Did you have a history of traumatic brain injuries? Where did you live? And so forth. And we also, like I mentioned, we also fund research. We also fund grants, and these grants are very, very important because these grants allow us to fund academia to figure out exactly what sort of areas that we potentially want to look at. So environmental factors is certainly very, very important. Cyanobacteria, exposures to heavy metals, and so forth. Genetics is also equally important as well. So we want to go ahead and make sure we can go ahead and fund these studies to figure out exactly what causes ALS and why. And so this is pretty much in a nutshell describes the National ALS Registry, and I'd be happy to take your questions after everybody testifies. Thank you, ma'am.
Thank you. So we will each have questions, I'm sure. And I'm going to start with you, Dr. Mehta, because so the information, should Vermont have a registry in place, then the information on Vermont's registry would automatically go to the National Registry? Trying to sort out.
So currently we have a request with the Office of Management and Budget, which handles data collection effort for the federal government. And this particular request from us to OMB is requesting new data sources. So this would also include state-based registries where we can go ahead and get these cases from state-based registries as well as other organizations as well. Currently, that system is not in place right now because the approvals are not there. But we are, like I said, in the process of requesting the approvals from the Office of Management and Budget to go ahead and request new data sources so we can go ahead and augment our case ascertainment methods.
Okay, so if we were to put a registry in place, then, and the Office of Management and Budget okayed your request, then that the information that we have in the state would be accessible to you. So it's working, or yes or no?
Well, I mean, that's certainly something we have to certainly talk to the state health department with, and it kind of go from there. And so certainly there's negotiations of data user agreements, privacy, and so forth. But in a hypothetical world, certainly that could be possible where we could take the data from, let's say, for example, Vermont or some other state, and go ahead and add those to the registry. We are currently doing a study, an evaluation of the cases in the state of Massachusetts. So we have their cases, and we're looking to compare what the proportion of cases are matching with the National Registry from the state of Massachusetts. And that currently is that data are currently being analyzed right now. So I can't really speak on behalf of the actual findings. But that's certainly an effort we're doing to compare data with another state, such as Massachusetts.
Okay, this is helpful. And then you talked about the epidemiology of ALS and how the registry would help you get at the cause, the etiology of the disease, but you're looking at it epidemiologically. Can you talk a little bit about how de-identified patient information might be accessed? How is that accomplished? How do you get all the data necessary? Is that something that happens at your level, or is it something that happens at the state level? How's that?
So the data that we receive from CMS or VA is actually identifiable data. And so we have robust data user agreements and privacy protections in place from these particular organizations, because we need to make sure who has these cases. Otherwise, there's a risk for potentially over quantifying the number of cases. So without having the PII, personal identifiable information, it is very hard for us to figure out exactly who Jane Doe, John Doe, whoever that is, who is coming to the registry is not being counted twice per se. So the cases that we currently are matching with the state of Massachusetts are currently identifiable cases. So we went to their IRB or their institution review board for the state of Massachusetts and requested these data from them to go ahead and do the comparison. But without PII, it's very difficult for us to actually see and match up who's got cases. And ma'am, one other thing I'd like to point out, because ALS is non-notifiable, there is a bulk. We know we're missing cases, and the cases we're missing are predominantly coming from the private pay. So for example, patients, if you're diagnosed with ALS, as Dr. Stommel and Dr. Tanner can certainly being clinicians and seeing these patients, we don't see patients here at the CDC. You can qualify for Social Security disability and then go ahead and get CMS care, as well as get care through the VA system. But there's a proportion of patients who actually will get their care through private pay. So for example, the Blue Cross Blue Shields of the world and so forth, they'll go ahead and opt in and stay on their healthcare insurance. And we can't see those patients as of right now. We're hoping to potentially negotiate with these particular insurance carriers in the future to potentially get their cases. But that certainly is something that we can't do right now.
Okay,
And
thank you.
I just also want to mention, it's very important. I mean, data by itself is very valuable, whether these data are coming from the local, state, or national level, everything helps. And it helps us to figure out exactly who's getting ALS and why.
Thank you. One other question that I have for you, it relates to the grants that you were talking about and how the potential support those grants might offer to our state as we go forward to put in place a registry.
So right now, the grants we currently have are going to academia. So if there was a potentially, let's say, a relationship down the future, there could be a way for us to facilitate some sort of funding to, let's say, a state to go ahead and get those, cases from the state and so forth. I can't speak to that funding as of right now, because right now our funding is pretty much, I wouldn't say capped, but pretty much spoken for. And so, our monies are already spoken for other initiatives at the registry. But this is actually a novel way of what CDC does. And, CDC funds state-based organizations. Newborn screening is actually a very good example where newborn screening, there are cooperative agreements with the state to go ahead and get cases from the states into CDC to go ahead and do the analyses. And this data are also shared back with the state as well. So it's not just a one road or a one-way system. These data are also shared.
So it seems to me then that a part of the process here is doing a genetic test, perhaps for an individual patient, and understanding is the SOD1 gene there? Is it familiar? Is it not? And so the testing might happen first, and then that would be part of the registry, so you could understand both at the state level, but then also at the federal level, the implications and comparing notes.
Correct. A lot of the testing for familial ALS is actually would be done actually at the clinic level. So Dr. Stommel, Dr. Tanner would go ahead and do that first when they see a patient to rule out familial ALS. We also do genetic testing on our end as well through the National ALS Biorepository.
All right, thank you. I'm going to ask two quick questions, and then I think the committee deserves an opportunity to ask questions. Dr. Stommel, you mentioned clusters, and when you were talking about the potential that we have ALS clusters along Lake Champlain, but that, for me, that's kind of a higher level term that you determine as a result of collecting data and evaluating the data. So when you say clusters, is that something that you have data to support, or?
Yes, we've published papers on it.
Okay,
And you can look at the references in the letter that Dr. Tannen and I wrote to you that address those clusters. Ascertaining clusters is the work of an epidemiologist largely, but we have geospatial experts helping us, geographers who use GIS software and their expertise. Can I just say something in regards to what Dr. Tandon said?
sure. But make it quick, because I do have a question I want others to ask questions. So
Yeah, okay.
Yeah, go
So
ahead.
just briefly, you were asking about grant money for the state of Vermont. Well, I've been lucky enough to get some funding from the CDC, and we've looked both at genetics and at risk factors for ALS, and a large part of those patients come from the state of Vermont. So that's some indirect benefit for ALS patients in Vermont through the CDC.
Okay.
So just wanted to make that
Yes,
clear.
thank you. No, that was clear in your testimony that you have worked with grant money from CDC. It's just, we're trying to sort out how to put all this together.
Sure.
So this is our first opportunity. So I'm going to ask committee members if you have questions at this point. Senator Hooker.
Thank you. And thank you, doctors, for being here. This is a really basic question. You've talked about ALS as being a rare disease. How rare is it? Do you have a general incidence of it? And how does that compare to what you know of the incidence in Vermont?
You're muted, Dr. Tandon.
Right. Can you hear me now?
Yes.
Maybe I can take that question. So the incidence of so there are two epidemiological factors that one has to consider: the incidence of the disease and the prevalence of the disease. So the incidence of the disease is the number of new cases that develop with the disease. And the incidence of ALS is about 2 per 100,000 population. The prevalence of the disease is the number of cases at any one time point with the disease. And the prevalence of ALS is anywhere from 6 to 8 per 100,000 population, closer to 6 than to 8, or maybe between 6 and 7, as Dr. Mehta's most recent paper would suggest. So that would suggest that there would be about maybe 45 to 50 cases of ALS in the state of Vermont. That's the prevalence of the disease. And when you compare the prevalence and incidence of ALS, it is not too much lower than that of some other neurological diseases like MS, but the prevalence is low because the survival is so short in people with ALS. So once you have a person diagnosed with ALS, they survive for half the population of ALS patients survive for about 3 years. So that the prevalence is low, though the incidence may not be much lower than that of some other neurological diseases like Guillain-Barré syndrome or MS.
Senator Hooker.
Thank
Is
you.
that-
Yeah, that I'm just curious to know. I mean, we hear anecdotal stories about the prevalence of ALS in Vermont, and I'm just trying to sort that out. Thanks.
Question, Senator Hardy, go ahead.
Thank you, Madam Chair. I have a couple specific questions and then a more general, I don't know, philosophical or scientific, whatever. Dr. Mehta, you were talking about the importance of having the identifiable data so that you can connect people to services. And Dr. Tandon, you also talked about that so that people who are diagnosed are able to get to the centers of excellence and get access to physical therapy, et cetera, all the treatments. But what we heard from our previous witness and scrolling through the bill, there's a desire that the information be kept confidential and not identifiable. So how do you square those two goals of keeping the non-identifiable data with the ability to connect patients once they've been diagnosed to services?
Just question for me? Or
Either one of you, because you both mentioned this issue. So I'm just curious how to square that.
Yeah, I'll defer to Dr. Stommel because obviously if there's about 40 or 50 new cases of ALS in the state of Vermont every year, you should be able to figure out exactly who these individuals are. And they could certainly be, what do you call, you could go ahead and shield their names and protect their names and protect their privacy as well. But what ends up happening is when you have a larger state, let's say the state of Massachusetts, where you have a lot more cases which are happening, that PI information is important, which securely goes to the state to figure out exactly that database right there, which is a secure database to figure out exactly who has the cases. Otherwise, you may end up repeating the number of same patients if they're seen by one provider, let's say one doctor in Burlington, Vermont, and one doctor somewhere else in another Montpelier, Vermont. Am I correct? Is that your capital? I can't recall. Yep. So what if you have two neurologists or two primary care physicians who diagnose ALS? They'll probably go to Dr. Stommel for a confirmation, obviously, but the premise is you have to have that matching sort of information. Otherwise, you could have the same patient be reported twice, but without having that sort of connector, you could also overinflate the cases as well. So, but I think there should be ways in place to protect the patient's privacy and so forth, to make sure that that they're housed securely. What Dr. Tandon was saying regarding the services available to these patients, that's very important. So, for example, I believe Dr. Stommel, correct me, I believe the Northeast ALS Association is the group that actually services the area right there, which provides care services for New England and so forth. These particular groups right there, they provide information, and they know who's got ALS in their backyard as well. So, but just for the sake of reporting, I think you'd have to have some sort of way to figure out exactly who's got it to make sure they're not being captured twice. Dr. Stommel, what do you think?
There's a precedence for that in Massachusetts, and between Dr. Tandon and I, as I mentioned, we have a certain percentage of the ALS patients in Vermont, and we know who they are. We're not leaking that information to anybody. At some point, we would want to go over each individual case and then put it in a very secure system like REDCap or what the CDC has, which is a different system, so that it's all protected and secure and unavailable to.
It just seems like it's a contradiction. If patients want their information confidential, but you want access to know who those patients are, even if they may not be your patients. So you, Dr. Stommel, would know who Dr. Tandon's patients are. And maybe you already know, but you know through these informal things, not through an official government registry. So that just seems to be a contradiction in the sort of desires of the patients and the desires of the benefits for the program. And then Dr. Mehta, how many people are in the National Registry, the voluntary one?
We currently have over 17,000 patients in the National Als Registry.
Okay.
And
And
we
is
launched
that
back.
identifiable data? You know who those people are?
The data we get are identifiable data, but what we give to researchers if they request any sort of data from us, that's all de-identified data. We don't share any sorts of names and whatsoever. And that's common practice where we have to figure out exactly who's got ALS to make sure that person is in CMS, is not also in our own self-enrollment portal, or also, for example, in the VA. So the data we get from CMS as well as the VA system is actually identifiable data. It's stored, it's housed, and then it's secured. And then we go ahead and do the analyses to figure out who is a case. And then from there, if they're a case, they remain a case until they pass away.
And do you know, you obviously don't know this number specifically, but do you have a guess, an educated guess of to what percentage that 17,000 is of people who have ALS in the country? What's the uptake of using the voluntary registry?
The uptake. So right now, the prevalence of ALS is there's between 20 and 30,000 cases of ALS in the US. That's what we estimate. There's a new paper that we're going to be producing, which is going to show the number of missing cases we have. And that's going to show a prevalence of about 7 per 100,000. And so, but there's between 20 and 30,000 cases of ALS in the US right now. Now, I can't tell you exactly how many of those we have in Vermont because we've not looked at that data. We have it available, but I can't report that to you. That's one of the other requests we have with the Office of Management and Budget, is to actually report the number of state cases for each single state in the US. That's also a request we have with the Office of
Oh, that's interesting. Then, so I have some further questions. I see you, Dr. Tandon. I just want to understand, you're all neurologists, right? Are you, Dr. Mehta, also a neurologist?
No, I'm not a neurologist. I'm just the general practitioner.
Oh, you're just a regular doctor?
Yes.
Well, so one of the questions that came up when we first started taking testimony on this was, ALS is obviously a devastating disease, and it's obviously a disease for which we need to learn a lot more. But that is true for a lot of other diseases. And I'm wondering why ALS above any other neurological disease. My own father died of a different neurodegenerative disease, which was also extremely devastating. And so why ALS be above any other disease?
I could just say this: ALS is a life-changing event. Other diseases out there, whether it's MS or some other neurological diseases, have treatments out there. ALS currently has no treatments. There's no cure. The only 2 drugs approved for ALS, on average, the patient will live for 2 to 3 months longer. And so currently what we have is a very, very limited therapeutic interventions available for ALS patients. And the fact that ALS patients progress very fast after they're diagnosed is really, really problematic. We're trying to figure out exactly if there are ways to potentially, Dr. Thalmo, Dr. Tanner can certainly chime in to either slow the progression, stop it, or even reverse the progression. Right now, there are no drugs which can currently do that. And like I mentioned, the 2 available drugs right now will only extend life on an average of 2 or 3 months only.
Well, is there an argument to be made that we could have a broader registry that captures more than just ALS, but may also capture other data on other diseases that may be more broadly useful? I certainly don't want to disparage the utility of having more data on ALS. I understand the significance of that, but going through a government registry, I'm just trying to figure out, how can we get more bang for the buck kind of question.
So I did allude to that in my testimony. ALS is a relatively easy diagnosis to make for somebody like Dr. Tandon or myself. Alzheimer's disease is actually much more difficult to make a clear-cut diagnosis. And usually that diagnosis is not made until the patient is deceased and an autopsy is performed. It's also very hard to study a disease like Alzheimer's disease when you can't ascertain all the cases you can't be sure about the diagnosis. And there's so many of them that it can be overwhelming. Whereas ALS is relatively rare, and they stand out, and the diagnosis is clear, and they are related to other diseases like Parkinson's and Alzheimer's disease and multiple system atrophy, progressive supranuclear palsy, Huntington's disease. They all have common mechanisms underlying how the disease occurs. And so I think it's very useful to study a disease like ALS because it's a manageable one to study. And maybe Dr. Tandon has something more to say about that.
Yes. So I'll answer your question, Senator Hardy. So I think that the reason why we would consider a separate registry for ALS is this. So the lifespan of an ALS patient, the median lifespan of an ALS patient is 36 months. Okay. The median lifespan of a patient with some other neurodegenerative disorder like Alzheimer's disease or Huntington's disease is much longer. And it takes about, on average, 9 to 12 months for patients with ALS to be diagnosed. So now they have spent a third of their lifespan not knowing that they have ALS, and then their disease progresses extremely rapidly. So we only have a limited period or window of time to act there, to provide them support, to give them the services that they need, to give them the treatments that they need, and to let them participate in clinical trials that might help them. So I think that ALS is unique in that perspective, in the sense that even though it's a rare disease, the incidence is low, the prevalence is not very high because of short lifespan, but the window of opportunity we have to manage and treat these patients is so small that we need to be certain that we know of all the patients with ALS as soon as we possibly can. Then we can intervene and help them.
Okay.
I'm gonna ask Senator Hardy if we can turn to Dr. Vos, who, because we have a short period of time, and what we could do is Dr. Stommel and Dr. Tandon, is there perhaps an opportunity for us to ask further questions? Well, don't go away, but perhaps there's another time we can bring you in. And Senator Hardy, I do apologize, but I think it's helpful to get Dr. Vos in, and then if there's time, we can ask further questions. What was your burning question? And then they can at least perhaps respond with a written testimony.
My question is about more of a regional registry, because Vermont is so small. If there's one already in Massachusetts and you're working on one in New Hampshire, perhaps we could have a New England registry that would be more cost effective and more scientifically useful. So that was the question.
Good question. So that's something to think about, and we would look forward to some comments on that. Dr. Vos, thank you for being here. It's good to see you again. And you're muted, I think. You're still muted. There it goes. Nope.
She's
Not yet.
Can't hear
Um, how about this one?
How about that? That works. Thank you.
Okay. Yeah, I have 3 different microphones on Zoom and they're never fun.
I hope you're not on 3 different Zoom meetings at the same time. Maybe you are. Okay. Why don't you introduce yourself for the record, and then we would like to hear your testimony regarding the ALS bill and registry.
Mm-hmm. Yeah. So my name is Sarah Vos. I'm the state toxicologist here at the health department, and I was invited to talk with you about the link between cyanobacteria and ALS specifically. Dr. Levine was here a couple weeks ago to provide some additional testimony. So I just first want to say that I joined this conversation with a lot of respect for the previous speakers, for the work that they do, as well as a lot of respect for the families who are dealing with ALS. So there's certainly no question that we need more research on the potential environmental causes of ALS. And I want to summarize both some toxicology and some epidemiology research for you all. I want to explain the difference between toxicology and epidemiology research. So toxicology studies are done on animals, and those are in very controlled environments. And we do that to understand the dose at which a chemical could cause health effects. And then we can extrapolate that to humans. Animals are often given really high doses of chemicals, much higher than what humans would be exposed to, but that does allow scientists to use fewer animals and make clearer conclusions. Epidemiology studies are those that tell us about potential exposures in humans, in people, and possible health outcomes. And those are, of course, much harder to do because we as people do not live in a controlled environment. So we've heard this morning about the hypothesis that exposure to cyanobacteria, and specifically the toxin called BMAA, could contribute to ALS. And I want to just, first outline our cyanobacteria program at the health department. We do encourage everyone to avoid cyanobacteria. BMAA is one potential toxin, and we know that cyanobacteria can make a whole host of other toxins. Specifically, microcystin is the one that we have focused on the most in our state. And we know that exposure to cyanobacteria and microcystin can make people sick, especially if they're recreating in water where there's a bloom. So we have produced a very short video to hopefully help Vermonters educate themselves about how to identify cyanobacteria so that they can avoid exposure. So thinking about the types of studies that have been done, the epidemiology studies, as has been discussed, these are mostly spatial analysis and cluster studies. And, clusters can occur by chance alone. And that's a really important concept in epidemiology to really tease out. One analogy that my director shared is that if you drop a handful of pennies, you'll see that they don't land evenly distributed, but they land in clusters of pennies. So the way to tease out whether there's a true association between an environmental exposure and a health outcome is to adjust for confounding variables. So I'll give some examples of these. So many people who live near a lake or on a lake might be older. They might be in retirement. They might be in the typical age range for diagnosis with ALS. So could it be that that's the possible reason for any reported association between living near a lake and ALS? Real estate near a lake is often more expensive, and if higher household income is associated with motor neuron disease or ALS, then an increased risk of ALS near a lake could simply be due to higher socioeconomic status. Temporality is also a really important concept when we look at these spatial analysis and clustering studies. So it can be unclear which came first, the exposure or the outcome. We don't know what the latency period is for ALS, so it could be possible that someone had environmental exposures to, we've heard about cyanobacteria, but also pesticides, solvents, metals. It could be possible someone had an exposure and then moved to an area near a lake 5-10 years later. So that issue of temporality is often not clear from those spatial clustering studies. There are also some issues with how exposure pathways are defined. Some of the studies use satellite remote sensing data as an indicator of water quality, and it's a fantastically interesting data set, and it's great to use for an indicator of water quality, but it's not a valid indicator of cyanobacteria exposure or exposure to toxins. Sometimes, BMAA has been, people have looked for BMAA in some of these studies and not found it in the water bodies where they're doing the research. And the papers don't often go into much detail about an individual's exposure. So it's not just living near a lake, it's how many times do people use the lake? Could people live farther away from the lake yet drive an hour every day to go recreate? So we definitely need to understand more about BMAA occurrence. We do not have any data on how prevalent BMAA is here in the Vermont cyanobacteria blooms. So certainly the next step to really help understand a potential link between cyanobacteria and ALS is to develop some high quality epidemiology studies. So these studies, the studies that have been done do have some weaknesses in their epidemiology methods, but they do serve to establish a hypothesis. So future studies would need to take into account these other potential risk factors, heavy metals, pesticides, tobacco use, age, head trauma, income. There are a whole host of potential confounding factors. These studies would need to use really rigorous definitions of clusters. This can be really challenging with low case numbers, especially here in Vermont, we have a low population. So studies done only in Vermont may not have enough statistical power to show some significant associations. Our previous speakers did publish a very well-conducted case control epidemiology study looking at ALS, and they did find some significant associations with pesticides, metals, and solvents. So living near a lake was not one of the strongest associations, nor was windsurfing, boating, sailing, kayaking, swimming. The one thing that was highly associated was water skiing twice a month for a year. But it just goes to show cyanobacteria is not a known risk factor for ALS. The epidemiology studies are not quite strong enough to make that conclusion. One other study that was published in 2020 looked at plasma from 153 people who were diagnosed with ALS and 118 people who were controls. And they did look for BMAA, and they did not find BMAA in any of those samples. Again, there is a hypothesis, but the data are not strong enough right now to make any strong conclusions about causality. So to summarize the toxicology studies, so these are the studies that have been done in animals in the past several years. It's maybe in the past 4 years or so. There have been a lot of improvements and a lot of publications on animal models looking at the potential for BMAA to cause neurotoxicity. So BMAA has been given in a single dose to rats and vervets. And vervets are a type of monkey. And both those animals have shown changes in their nervous system, which can reflect neurotoxicity. These aren't exactly complete toxicology studies yet, because we really need to see many doses. So seeing that health effects increase as a function of dose is a very important concept to establish that a health effect is associated with the chemical. In addition, some of the research on animals exposed to BMAA report changes that are more similar to other neurological diseases such as Alzheimer's. So it's not very clear right now that BMAA, when given to animals, produces a clear animal model of ALS. But again, these toxicology studies, both in animals and in cells, do point out the potential for BMAA to be neurotoxic and underscore the importance of conducting more high-quality epidemiology studies. So just to circle back to our cyanobacteria program, we do work with partners in the state. So we work with Lake Champlain Committee and Department of Environmental Conservation to train a network of volunteers. They're reporting about conditions mostly in Lake Champlain. We do have some monitors in other parts of the state. We publish those conditions on our website. We do outreach to towns when we know of a cyanobacteria bloom, in the hopes that towns can post clear signs so that people, if they haven't seen our video and if they aren't aware of how to identify cyanobacteria, that they will see the sign and know that they should avoid that water. And we also test the public drinking water systems that are on Lake Champlain. They've been tested weekly for the past several years in the summer for microcystin. So just to summarize, we are encouraging all Vermonters to avoid cyanobacteria, not specifically because of the risk of ALS, but based on what we know from other toxins and the health risks. So I'm happy to take questions.
Thank you. That was very helpful. I think there is always the information floating around that suggests a direct cause between cyanobacteria and ALS. And until we have a full understanding, research completed, we're not going to be able to say that. So I think it's important I'm very pleased that you brought the information to us. It would be helpful to get it in writing, or at least a summary of your comments in writing. That would be terrific.
Yes.
I will ask the question, and it's actually for all of the experts who we have here with us today, and that is, will a registry help us move toward greater epidemiological understanding? If we have a registry, will it be useful to us in identifying causal relationships or other? And I'm open to who would like to raise their hand and just sort of talk about that a little bit.
I don't, can you hear me?
Yeah.
Okay, so I think, yes, having a registry with very accurate assessments of incidence and prevalence of ALS in any population, in any border, is very important. We've tried to get a registry in New Hampshire, and it all boiled down to worries about finances. So to have a sort of Northern New England registry is maybe not something we'll be able to do in the near future. I know it is on the legislation in Maine this year. The governor of Maine is interested in having a registry for ALS. I don't know how that's going to go. I don't have too much to do with Maine, although I do see some cases from Western Maine. So I think that's my opinion on that. I would point out, if I'm allowed to, that we have many peer-reviewed articles in good journals discussing risk factors for ALS, including cyanobacteria. And the animal models, the toxicology models that have been done, including the vervet monkey, are very compelling. And there were doses given, and they even introduced an amino acid to block the DMAA. One last thing I'd say is that a lot of the other toxins haven't been looked at. We've found DMAA in many water bodies in Vermont and New Hampshire in areas where we've had clustering. Not all that data is published, but if you take one of the other toxins like antitoxin AS, the S stands for salivation. It's a very, very toxic substance. It's one of the toxins that kills domestic animals like dogs if they drink the water when there's a bloom. Pesticides have been linked to ALS and to Parkinson's disease even more strongly. Antitoxin AS is 2,000 times more potent than the typical organophosphate pesticides that are put on farm fields, 2,000 times more potent. So I think there's still a lot of research to be done on cyanobacteria in general and neurodegeneration. And we'd like to continue doing it on our population of ALS patients in Vermont and elsewhere in New England.
So I'm trying to draw a conclusion here that your sense is that a registry will help identify causal relationships, or at least some clustering. So is a registry
to have an accurate assessment of the number of cases of any disease is why registries exist in part. And then all the things we've talked about today, how they can be helpful for patients, can be helpful for services for patients. There are many reasons for a registry, but I don't see any downside to having a registry in the state of Vermont for ALS. I think would be an excellent thing to do.
Okay. Any final questions from the committee? Senator Hardy.
Just to be clear though, a registry would not have any impact on causal relationships. Just that, I mean, I'm not a toxicologist, but based on what we just heard from Dr. Vos, I mean, you need much, much, much more information than just where somebody lives to create a causal relationship.
Yes,
No,
but the question is, based on a registry and identification of folks, can you do epidemiological analysis, and how do you use that perhaps to develop relationships? That's really, is the registry helpful in that?
it's the bread and butter of epidemiologists
Okay.
to certain cases. Sharing that data with the National Registry would be very important. Yes, it has everything to do with epidemiology.
Okay, yeah, no, it's just in how you look at it.
And what data you collect, because
Yes,
this
exactly.
registry would collect pretty limited data. It's not like we're going to collect a huge amount of survey data about everybody's.
Right. It's the beginning. Okay, this has been very helpful. There's probably a lot more that we don't know that we need to know, and we may circle back with our questions if that would be appropriate and acceptable to you folks.
Yes.
Terrific. Okay. Thank you. So committee, we can go off YouTube. I think our